Good afternoon, everyone. My name is Mariah Earhart. I am with the Center for Rural Health, and thank you for joining the State Office of Rural Health webinar series. Um, Before we get started, I wanted to go over kind of some ground rules, so to speak. You will be muted throughout the presentation, but we encourage you to put questions in the chat. There'll be some time afterwards to answer those questions or an email to give those questions to if they come up later in the day. This webinar is being recorded and will be posted on our website for future viewing. So if someone else may benefit from this, absolutely please share that link. And lastly, I want to take a moment to respectfully acknowledge that the University of Arizona is on the land and territories of Indigenous people. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. The university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education offerings, partnerships, and community service. And with that, I will hand it over to Salina, who is our presenter for today.
Hi, everyone. My name is Salina, and I am a member of the American Lung Cancer Screening Initiative, or ALSI for short. I am also an undergraduate student at the University of Holy Cross in New Orleans. And today we will be presenting a short presentation on lung cancer and lung cancer screening and our work as ALSI to increase awareness and, education about these topics. I am very heavily involved in underserved and vulnerable patient populations, and I hope to attend medical school in the future. So I am always grateful for these opportunities to present. Before we get started, I'd like to request that everyone is muted during the presentation. However, I would love to take any questions at the end of the presentation, so please feel free to put your questions in the chat box for us to answer. If you are interested in learning more about the American Lung Cancer Screening Initiative, or ALCSI, we'd like to invite you to visit our website, www.alcsi.org, and please email us with any questions at any time. And our email is listed at the bottom of this slide. So before I get into the content of the presentation, I'd like to share a little bit about what the American Lung Cancer Screening Initiative does. ALSI is a 501c3 nonprofit that works to raise awareness for lung cancer and lung cancer screenings. We are a team of over 500 passionate students and doctors located across the United States, and we have chapters in various colleges as well as medical schools nationwide. We've worked with community organizations like the South Asian Network and American Indian Cancer Foundation, as well as city and state health departments, including New York and Connecticut health departments. We hope that in educating communities about lung cancer and lung cancer screening, high-risk members will be encouraged to seek lung cancer screenings. So today we will be discussing both lung cancer and lung cancer screenings, addressing questions such as how common lung cancer is, what lung cancer screenings are, and how you can get screened. To start things off, lung cancer is very common. It is the second most common cancer in the US, excluding skin cancer. This graph shows the American Cancer Society estimates for the number of new cancer cases in the United States. This graph estimates new cancer cases in 2022 for the most common cancers. And as you can see, it was estimated that about 236,740 people were diagnosed with lung cancer in 2022 in the US. So to put this number into perspective, it is estimated that about 6% of people will develop lung cancer during their lifetime in the United States. And that means about 1 in 15 men and 1 in 17 women will be diagnosed with lung cancer. Moreover, not only is lung cancer very common, but it is also very fatal. Lung cancer is the leading cause of cancer-related deaths in the US and the world. In 2022, it was estimated that lung cancer claimed the lives of 130,180 people. This graph shows the American Cancer Society's estimates for the number of cancer-related deaths in the United States. As you can see, lung cancer is far more fatal than breast, prostate, and colon cancer combined, causing more deaths than all three of those. Lung cancer makes about almost 25% of all cancer deaths, resulting in about 350 deaths per day. So every year there are about 50,000 more new cases of breast cancer, but lung cancer causes over 90,000 more deaths. So, if we take a minute to look at lung cancer incidence and mortality rates by sex and race, you can see that among males, lung cancer incidence rates were highest in Black males at an incidence rate of 71.7 per 100,000 people. Among females, lung cancer incidence is highest in white females at an incidence rate of 51.1. So, mortality rates mirror incidence rates. So, that means that Black males have the highest mortality rate among the population of males, while white females have the highest mortality rate among the population of females. So, from this data, the question that arises is why is lung cancer mortality so high? Well, lung cancer mortality is so high because patients are typically diagnosed at a later stage. This is a graph looking at the proportion of patients with lung cancer by stage. So, stage is basically a way for doctors to classify a cancerous tumor based on tumor size, if the cancer has spread to lymph nodes, or if the cancer has spread to different parts of the patient's body. Currently, most lung cancers are diagnosed at a distant stage, so this means the cancer has spread beyond the original site of the lung where it was originated. And this graph on the slide is based on data from 2008 to 2017, published by the National Cancer Institute. As you can see, about 21% of patients were diagnosed at a localized stage, while about 51% of lung cancers were diagnosed at a distant stage, where the cancer spread to other locations in the body. So, why is this important? Well, it's important because the stage that lung cancer is diagnosed at correlates directs with the survival. And we'll see this in the next slide. So, one way that doctors track the survival of patients is by looking at the 5-year survival. As you can see, the 5-year survival for lung cancer at early stages is high, but the 5-year survival significantly drops as the disease progresses. And this graph is just another way to understand the relationship between the stage at diagnosis and the 5-year survival. So the 5-year survival with patients with localized lung cancer is 59%, but only 23% of the lung cancers here were diagnosed at this stage. In comparison, nearly half of the lung cancers were diagnosed at a distant stage. And this is why early detection of lung cancer is important, because if we detect lung cancer at an early stage, then treatment options are better and prognosis is better. So, with lung cancer being such a morbid disease, some of you might be wondering why the majority of lung cancers are diagnosed at a later stage. So, a majority of patients are diagnosed with late stage lung cancer because they don't normally start feeling any of the symptoms until the cancer has grown and spread to other areas. So, let's talk about some of the most common symptoms. Well, some of the most common symptoms of lung cancer include chronic cough, coughing up blood, chest pain, and shortness of breath. Additional symptoms include hoarseness, loss of appetite, fatigue, persistent lower respiratory infections, and a new onset of wheezing. However, when people become symptomatic, the cancer has grown and spread to a point where it's more difficult to treat and the prognosis is generally poor. So, if the diagnosis of lung cancer has to wait until the patient has symptoms, it is difficult to catch the lung cancer early. So, the question we ask is, how do we catch lung cancer if the patients are asymptomatic? One of the best ways we can do this is lung cancer screening. So, lung cancer screening is usually done through something called a low dose computed tomography or a low dose CT scan. It is recommended that you get your annual lung cancer screening if you are eligible for it. In the coming slides, we will be discussing what lung cancer screening is, who should get screened, and how you can get screened. An important distinction I want to make right off the bat is that lung cancer screening is usually done through low dose CT and not chest x ray. We use low-dose CT because it provides more detailed pictures than a chest X-ray. So it's usually better at finding smaller abnormal areas in the lungs. The picture on the left here is a picture of a chest X-ray. The yellow arrows are pointing to the abnormal areas in the lungs, but the overall detail of it is pretty unclear. On the other hand, on the right side, you see a picture of a low-dose CT scan of the chest. And the red arrow right here is pointing to an abnormal area in the lung. And as you can see, this image is more detailed than the chest X-ray and enables us to see the abnormal area with much greater detail. The questions that researchers want to answer now is, how effective is the low-dose CT scan at detecting lung cancers at an early age? So, an important lung cancer screening trial called the National Lung Screening Trial, or NLST, tried to answer this question. The NLST was a large national study with over 50,000 patients. The goal of the study was to determine the effectiveness of using a low-dose CT scan to detect lung cancer in patients. Considering these patients were basically usually considered high risk for lung cancer. So the study included two groups. There was a group of patients who received annual low-dose CT scans, and then a group of patients who received an annual chest X-ray. And so by comparing the stages at which the cancers were caught between these two groups, the studies wanted to determine if the low-dose CT scan was better at catching lung cancer than the chest X-ray at an earlier stage. And as you can see, of everyone diagnosed with lung cancer, the low-dose CT scan caught the most lung cancers at an early stage, while the X-ray caught diagnosed patients at late stages, like stage 4. This has important implications for survival. Because the low-dose CT scan caught more lung cancers at an early age, these cancers were much likely to be treatable, and the prognosis in these patients were generally much better. This translates to a 20% reduction in mortality for those who underwent lung cancer screening using low-dose CT compared to chest X-ray. A concern with any screening test is usually accuracy. Essentially, how good is the low-dose CT scan at catching lung cancer? So, for every 100 individuals undergoing CT scan for lung cancer screening, 75 will be negative. Of those 75 that are negative, 97.7 to 100% truly do not have lung cancer. So that means that the test is pretty good at identifying the people who do not have lung cancer. So that is, if you do have the lung cancer, the test will most likely come back positive, and the test will not miss your cancer. So, if we move our attention to the 25 individuals that are positive, 23 turn out to be negative for cancer, primarily with follow-up imaging alone. This means that even if your test result is a false positive, it is really easy to rule out cancer using further non-invasive imaging. The two individuals that have a positive test result and truly do have lung cancer are more likely to be diagnosed at an early stage than if they were not undergoing lung cancer screening. This means that their treatment options and prognosis are just much better. The results of the NLST were published in 2011, which was a really long time ago. Several studies have been published since then, further confirming the life-saving benefit of lung cancer in high-risk populations. And one of the most important of these studies is the Nelson trial. So, in February of 2020, the results of the Nelson trial were published. Like the NLST, the Nelson trial had two groups. However, unlike the NLST, the Nelson had a group that received low-dose CT scans and a group that received no screening of any kind. A total of 13,159 men and 2,594 women between the ages of 50 to 74 were randomly assigned to undergo CT screening at a baseline, year 1, year 3, year 5, or no screening at all. The results confirmed the life-saving benefit of lung cancer screening by using low-dose CT. In the screening group, 58.6% of lung cancers were diagnosed at stage 1. In the non-screening group, 13% of lung cancers were diagnosed at stage 1. Early detection translates to a reduction in mortality. In the low dose CT group, there was a 24% reduction in lung cancer mortality in women when compared to no screening. And the Nelson trial also showed that with improvements in low dose CT technology, the false positive rate was also reduced significantly. So, we have proved through many studies that lung cancer screening significantly reduces lung cancer mortality and improves survival rates. Well, who should get screened for lung cancer? So, the United States Preventative Task Force, also known as the USPSTF, sets guidelines for who should be screened for lung cancer. Right now, they recommend that people between the ages of 50 to 80 who have a 20 pack year smoking history or greater and who are currently a smoker or formerly smoked or and quit within the past 15 years should get annual low-dose CT scans. I want you to keep in mind what a pack year is. So the current screening guidelines require you to have a 20 pack year smoking history. Now, pack year is probably a term that most of you have not heard before if you're not a physician or in the healthcare field, but it is basically a way for doctors to track your smoking history over a period of time. So a pack year is generally defined as smoking a pack of cigarettes per day for a year. So, for example, if you were to smoke one pack a day for 20 years, that would equate to a 20 pack year smoking history. Alternatively, if you were to smoke two packs a day for 10 years, that would also equate to a 20 pack year smoking history. The important takeaway here is that there are many different ways to reach 20 pack year smoking histories or greater, and a pack year is a great way for doctors to track your smoking history. I'd also like to point out that the guidelines set by the USPSTF were also recently updated. So prior to them being updated, they had slightly different guidelines, and they updated this in March of 2021. So previously, the screening guidelines recommended individuals between the ages of 55 to 80 with a 30 pack year smoking history or greater. And under the new guidelines, they've lowered that number from 55 to 50 and 30 to 20 pack years. So these new guidelines nearly double the number of eligible individuals for lung cancer screening in the United States. And notably, the most apparent increases in eligibility will occur among women and minorities. However, while these new guidelines will include more high-risk individuals, they only include individuals with heavy smoking histories. There are other risk factors for lung cancer that are not accounted for in the current screening guidelines. So, smoking is the primary risk factor for lung cancer. When compared to people who have never smoked cigarettes, a current smoker has about 25 times greater risk of lung cancer. About 8 out of 10, or 81% of deaths from lung cancer in 2022, were caused from smoking cigarettes. After smoking, the next leading cause of lung cancer was exposure to radon gas, which is usually released from soil and can help build up indoors. Moreover, secondhand smoke can also cause almost 3% of new diagnoses of lung cancer, and it is also expected to cause about 3% of deaths from it in 2022. Additional risk factors usually include exposure to asbestos, family history of lung cancer, COPD or chronic obstructive pulmonary disease, and previous radiation therapy to the lungs. It is important that we recognize these additional risk factors because although lung cancer has a strong association with smoking, there are a large number of people in the United States who have never smoked who do still get lung cancer. So, never smokers are defined as individuals who have smoked less than 100 cigarettes in their lifetime. Because lung cancer has often had a strong association with smoking, people are often surprised to learn that lung cancer in never smokers accounts for about 10 to 20% of lung cancer diagnoses and is the eighth leading cause of cancer-related deaths in the US and the world. More never smokers die from lung cancer each year than people die from ovarian cancer, which is really, really interesting. This graph shows the proportion of lung cancer cases that occur in people who have smoked in their life and people who have never smoked in their life. And it is then further broken down by whether there are current, former, or never smokers. And as you can see, 80 to 90% of lung cancers occurred in people who have smoked during their lifetime, and about 10 to 20% occurred in never smokers. And interestingly, women are more likely to be never smokers when diagnosed with lung cancer. In fact, in the US, 60 to 70% of never smokers diagnosed with lung cancer were women. And right now, lung cancer screening is not recommended for individuals who have never smoked. However, understanding that lung cancer in never smokers um, is a cause, uh, this is also a field of current focus of research right now because people understand that this is a cause. So, with the development of new screening technologies and high risk models, there may be a way to identify high risk never smokers who should be screened for lung cancer. Excuse me for a second. So, in summary, lung cancer is the leading cause of cancer-related deaths in the US. It is so deadly because most lung cancers are diagnosed at a late stage when they have spread to other locations in the body. Importantly, the early detection through lung cancer screening by the use of low-dose CT scans can reduce cancer mortality up to 33%, which is a big, big jump. Currently, only 5.7% of high-risk individuals are currently getting screened for lung cancer. To highlight how low this number really is, I want to compare this to the screening rates for breast, cervical, and colon cancers. And all four of these cancers have screening tests that are also recommended by the USPSTF. Right now, only 5% of high-risk individuals are getting screened for lung cancer, and this rate is extremely low in comparison to the screening rates for the other types of cancers. And the American Lung Association also estimates that if we were to screen every high risk individual recommended by the USPSTF in the US nationwide, we would be saving about 50,000 lives. However, we are only screening 5.7%, which means that a lot of lives that could be saved are not being saved. And why is that? So, the lung cancer screening rate is low for a number of reasons, including limited awareness, limited education, concerns about access to screening, the cost of screening, and the safety of screening. And so, in the next slides, we will be discussing this. And I really want to tell you that the important takeaway here is that lung cancer screening can help reduce an individual's risk from dying from lung cancer, and so it's very important. So the first potential concern is always usually the cost. As an advocate myself with ALSI and in a population in New Orleans here where there's a bunch of high risk individuals, I've realized that many people aren't getting screened because it's very costly. So the cost, the average low-dose CT scan costs anywhere from $300 to $400, and most insurance companies, including Medicare and Medicaid, what people do not realize is usually they will cover the cost for eligible patients. However, there are a few exceptions. Medicare will only cover lung cancer screening until the age of 77. Not all state Medicaid plans cover lung cancer screening, and patients will still pay the usual fees for provider appointments before and after the scans. As I just mentioned, unfortunately, not all state Medicaid plans cover lung cancer screening. Here is a map that was updated in September of 2021, and it showed which state Medicaid plans do and do not cover lung cancer screening. The blue states have state Medicaid plans that cover the screening, where the purple states do not, and in the pink states, the data is not available. So as you can see in Arizona, it is covered, and in Louisiana, also where I'm from, it is also covered. So the first step to getting screened for a patient is for lung cancer is having them talk to their primary care physician. Usually, almost always, you need a primary care referral to get screened. There are certain questions that a primary care provider has to ask the patient, and topics have to be discussed that are usually personal, sometimes such as smoking history. Pack your smoking history is one of the things that they calculate in these appointments. So to find accredited lung cancer screening centers, patients can usually go to the American College of Radiology website and they can type in the state from where they're from or which city they live in to find where accredited lung cancer screening facilities are located near them. So the American College of Radiology website is listed at the bottom left hand of this screen, and this is a map of accredited lung cancer screening centers in Massachusetts, and it's an example because our team it actually started in Massachusetts and it's grown nationally. So, as you can see here in Massachusetts, each red pin represents an accredited screening center where you can go get your lung cancer screening. As far as how the experience of getting a low-dose CT scan goes, it usually requires you to lay down on your back for about 5 minutes. You'll be doing something very similar to the patient in this image here. And one thing to note that is this process will not hurt at all because this is not using contrast. So that means that you're not using any needles or injections. And the low-dose CT is usually non-invasive, fast, and completely pain-free. Additionally, the amount of radiation exposure is very low. A way for doctors to measure the amount of radiation in a patient may receive, so usually the amount of radiation a patient may receive, this is usually, like it's usually measured and compared, during different activities and over time. So for a low-dose CT scan, you will be exposed to about 1.5 to 2 millisieverts of radiation. So this is a lot lower than a full CT chest scan where usually you will be exposed to a radiation dose of 8 millisieverts. To put that into perspective, you are exposed to about 3.1 millisieverts of radiation a year just from breathing, cosmic radiation, eating, and the radiation from Earth. So a low-dose CT scan exposes you to less radiation than you are exposed to from just existing on Earth, which means that the level of radiation you receive from an annual lung cancer screening test is very small. That being said, that this is always something you want to discuss with your primary care provider. All right, so a patient talked with their primary care provider, the PCP referred to the patient to a screening center, and they received a low-dose CT scan. Well, what's next? Well, the doctor will review the results of the patient screening test and follow up to go over any results. As far as the results go, there are three most likely outcomes. The first outcome is that the scans are normal, but so the first outcome is that the scans are normal, and if that's the case, then the patient usually looks to get the repeat scans each year. If the scans are not normal but probably benign, then the patient usually talks to their doctor about next steps, and usually these next steps include further scans, tests, or biopsies. And if the scans are abnormal or suspicious, then the patient will most likely have to undergo additional testing to confirm, such as a biopsy. So, lung cancer screening saves lives, but a question you may be wondering is, can individuals get screened when the pandemic occurred? So, as we all know, that when the pandemic occurred, a lot of restrictions were put into place as far as social distancing, wearing masks, and the COVID-19 pandemic just kind of posed a general risk in our population nationwide, especially for high-risk individuals. And so, during the pandemic, the number of cancer screenings decreased significantly. However, lung cancer did not stop because of the pandemic. So, if a patient was at high risk for developing lung cancer during the pandemic, it was very important, first of all, for them to have those annual screenings so that they were aware. Um, and most hospitals, right now and even like months after the pandemic when they were still recovering, had patients wear like a mask during their entire lung cancer screening process. So if the patients followed the necessary precautions like wearing a mask, social distancing, lung cancer screening during the pandemic was generally safe. But the pandemic did not, and in the future, if any, if anything as such or as similar arises, it should not deter patients from getting screened just because of certain restrictions, because it was proven to be very safe during the COVID-19 pandemic. Another question we often get is how vaping and e-cigarettes use affects lung cancer risk. So, vaping and e-cigarettes are relatively new phenomena and have become more prevalent in the last decade. While the long-term effects of vaping and e-cigarettes are still being studied, it is clear that for individuals who have never smoked before, they can increase their risk of lung cancer. And e-cigarette devices and vaping fluids contain nicotine derivatives and heavy metals, among other chemicals. So, these arise both as elements of the e-liquid and as a result of organic reactions in the electronic cigarette device. Various studies demonstrated in vitro transforming and cytotoxic activity of these derivatives. So, vaping causes fewer health risks than smoking, but it is not entirely risk-free. So, vaping can actually increase heart rate, decrease air volume in the lungs, and increase airway resistance. Furthermore, e-cigarette devices and the usage of these devices has been significantly increasing, particularly among the younger adults and non-smokers. So, it is definitely an area for significant concern in the future and also should prompt significant research in the future. Additionally, while lung cancer screening has the potential to save many lives, it is important to address smoking cessation in the context of lung cancer screenings. Lung cancer screening is not a substitute for smoking cessation. Likewise, smoking cessation is not a substitute for lung cancer screening. Smoking cessation is one of the best ways to prevent lung cancer, and lung cancer screening is the best way to detect lung cancer early. So, using both and kind of having both work together is the best way to fight this disease. For every year after an individual quits smoking, the risk for lung cancer reduces by 8 to 17%, depending on the kind of lung cancer they have. Another reason that smoking cessation is important is because it's required by Medicare and Medicaid services for lung cancer screening programs. However, we do understand that smoking cessation can be difficult, but there are a lot of resources for people to try quit smoking. Some of these great programs include the renowned Health and Wellness Quit Smoking Program and the Nevada Cancer Coalition's Quit Smoking Program. And I'm sure there are many others nationally, including in Arizona as well. So, as this presentation comes to a conclusion, I want to end on what as the American Lung Cancer Screening Initiative, are doing to begin the widespread awareness, education, and advocacy for this topic, and what efforts we are making to increase lung cancer screening rates. And as I've said multiple times in this presentation, lung cancer is the deadliest cancer in the world. And while lung cancer screening saves so many lives, very few high-risk individuals are currently getting screened. And so we are working to address all aspects of this issue. We are currently working to increase education. We have chapters nationwide, including in the Louisiana, where I'm from, in Massachusetts and California. And these are usually college chapters in universities, as well as medical school chapters. And in these chapters, we do a wide variety of things, including webinars to increase education. We go out into the community and we teach our communities about lung cancer and lung cancer screening. We also worked with the White Ribbon Project to increase awareness and highlight lung cancer survivors and their stories as well. And we have also worked with the House and Senate resolutions for expressing support for Lung Cancer Awareness Month. So we have secured proclamations from many different cities and counties nationwide. Of course, as a team effort, where we have secured proclamations to proclaim November as National Lung Cancer Awareness Month. In addition, we have also we're working on, so we passed a bill in Massachusetts, and we are also working on passing one in California as well, and basically advocating for this at the government level as well. But we also work with local representatives and city officials to raise awareness for lung cancer and lung cancer screening. So I personally in New Orleans have worked with them on not only to increase awareness through like radio ads or like through TV ads or through just, getting out in the community and just making like kind of a public service announcement. Because, you know, we can save millions of lives all by working together to raise awareness and initiate lung cancer screening programs in our communities. And we believe that educating communities, especially students, is crucial to lowering the number of deaths associated with the disease. So students greatly impact and influence the healthcare of their patients, and we hope that by educating students and by educating healthcare professionals, just per people in our community as well, these are important measures that not only will help our future generation, but it can also help family members and, of course, those who are eligible for screenings. Thank you.
Thank you, Salina, for the really well done presentation. We did have one question that I wanted to bring to your attention, which is,
Mhm.
do we have any idea why women who have never smoked seem to be diagnosed with lung cancer at a significantly higher rate?
So, no, we do not. That is a current area of focus that we work. So another thing we do as ALSI is we do research. We do research at a national level. So what we've found though is that that's really the main area of concern for for a lot of our a lot of our members. We have realized that lung cancer screenings are greatly beneficial for those who are eligible, but for those who are not eligible, like for never smokers, for women who are not eligible for lung cancer screenings and may have been exposed to secondhand exposure, or maybe they were exposed to asbestos, just those additional risk factors. That is currently an area that we are working to research, because if we can find a way for women, for populations such as women who have never smoked to get screened, we can help, increase the rates of those getting screened nationwide, and decrease the mortality rates as well. But no, we do not have an answer for that at this moment.
Thank you. I don't see any other questions right now, but in case any come up or people are just interested in getting more involved, is there a link or a website
Yes.
that they can visit?
Yes.
Perfect.
So, if you are interested in lung cancer screening, if you would like to join as a member, a volunteer, if there is a chapter near you, I'm not sure if there is one at the University of Arizona, but I do know that there are some chapters in Arizona, that are currently entirely student led, and we work nationally, so we have meetings every single month between all of our chapters. But if you are interested, you can go to our website at www.alcsi.org, and you can also see a lot of the initiatives that we're doing in our communities nationwide. So you can see the proclamations, you can see the bills that we've passed in Massachusetts. You can see like the teams working all around the clock. Volunteers. I should add that these are all volunteer led, that are working all around the clock to ensure that we we get those screening rates higher. So, and then if you do have any more questions, please feel free to email this email below, info@alc.org. And yeah, it would be great if you guys developed a passion for this and you would like to join, and simply just kind of tell people about this. Being an advocate for patients, that is something that is also very, very, it's very beneficial and it's very important. And so, if that is something that is of interest to you, you can also head over to this website and just go to the tab where it tells you to join, and fill out the form.
Thank you so much, Selena, for your time today. And as mentioned earlier, this webinar was recorded and the slides will be posted with that recording. So
Mhm.
you'll receive a follow-up email with a link to that and feel free to share it with anybody else that might be interested.
Yeah, sounds great.
I hope you all have a great day.